So here we are going to focus on respiratory system, function, and disorder. In part 1, we already discussed the anatomy and physiology review and also diagnostic test included in part 1. And part 2 basically talk about the disease. Okay. So first one is called chest injuries. In this picture, we can see this is called sternum. And this is the ribs. The lungs is covered by ribs, and these ribs is protect our lungs. Unfortunately, if the rib fracture occur, like this picture, the ribs is broken. Imagine, unfortunately, if any bad road traffic accident or falling from the height or any other trauma, the fracture occurred, we call chest injuries. So the chest injuries, because of the fracture of the ribs, result from direct blunt chest trauma and causes a potential for intrathoracic injury, such as pneumothorax or pulmonary contusion. So this is the ribs is broken. My lungs injured, penetrate. Air is inside the pleural space and pneumothorax develop, or pulmonary contusion. Pain with movement and chest splinting result in impaired ventilation and inadequate clearance of secretion. So secretion accumulate. Alveolar sac will full of fluid or will full of blood, and they will not contract or relax as normal. Also, patient complain of chest pain. If any patient have a chest injuries, fracture of the ribs or trauma, they usually present in the hospital with pain at the injury site that increase with inspiration. This is the character of chest injuries pain. Tenderness, shallow respiration or respiration rate, and also client splint chest, fracture note on chest X-ray. So if we take a radiography of the chest, we can see the chest fracture, rib fracture in radiological image. In this picture, we can see the fracture occur in the ribs and also lungs contusion, penetration, and hematoma formation. So what are the intervention? Note that the ribs usually unite spontaneously and space the chest in a high polar. So if patient have this problem, we encouraging them position of the patient. It is high polar position. Administer pain medication as prescribed to maintain adequate ventilatory status. Monitor for increased respiratory distress. Also reinforce. Educate your client to self-splint with hands and arms, or prepare the client for intercostal nerves block as prescribed if the pain is very severe. What next? Next topic here is called failed chest. So what is failed chest. It is almost like the chest injuries, but little bit different. In this picture, we can see fracture of the ribs in multiple positions. Because of the fracture, during the inspiration, the structure go inside of the lungs, failed segment go inside, and during expiration, the broken part of the lungs is bulging outside. So failed chest occur when the blunt chest trauma associated with accident that may result in hemothorax and rib fracture. So in this picture, we see the ribs is broken in multiple sites, and also blood is accumulated in the pleural space we called hemothorax. The loose segment of the chest wall become paradoxical to the expiration and contraction of the rest of the chest wall. So what does it mean, paradoxical? So I said during the inspiration, the segmental portion go inside, but during expiration, the broken or segmental parts go bulging outside. Or two lungs not symmetrical during inspiration and during expiration, right? It is called paradoxical respiration. How patient present if the patient have a filled chest, paradoxical respiration, severe pain in the chest, or shortness of breath, or dyspnea, cyanosis, because tissue does not get enough oxygen, blue discoloration, and this is called cyanosis, tachycardia, hypotension, tachypnea, and diminished breath sound. Next here, the mechanism of a filled chest. Let me recap something. So in picture number 1, we see this area is broken, fracture, or blunt injuries. Ribs are broken. So this area loose part of thoracic wall. During inspiration, this area go inside, and during expiration, this loose part bulging outside. And mediastinum is shifted with each breath, right? So it is when inspiration, it should be go opposite direction. During expiration, mediastinum also bulging towards the loose side. Same picture where we can see paradoxical respiration and filled segment. And it's a mediastinum shifting opposite side and bulging to the loose side. In this picture, we can see the chest injuries. What are the intervention? Maintain the client in a polar position. Administer humidified oxygen as prescribed. Monitor for increased respiratory distress. We encourage the coughing and deep breath exercise. Also, administer pain medication as prescribed. Maintain the bed rest and limited activity to reduce oxygen demand, because my lungs is not enough to get the oxygen. So it is good to reduce the activity, so demand will be less, or prepare the intubation with mechanical ventilation to severe the flinches associated with respiratory failure and shock. Now go another key medical condition, pulmonary contusion. What is pulmonary contusion? It is characterized by interstitial hemorrhage associated with intra-alveolar hemorrhage, result in decreased pulmonary compliance. The major complication is acute respiratory distress syndrome. So pulmonary contusion. See this picture. This is the normal alveoli, and this is the inflamed. I'm not going to compare and contrast normal and inflamed alveoli. I am here to show you this area is called interstitium, and this is the blood vessel, red blood cell supposed to in the capillaries. This red blood cell carry oxygen and carry carbon dioxide, and oxygen we get in alveoli from air. So in interstitium and lining epithelium helps to exchange oxygen and carbon dioxide. The problem is in contusion, interstitium hemorrhage occur, means bleeding occur in that area, in interstitium or lining epithelium or along the basement membrane. When contusion occur, contusion lead to acute respiratory distress syndrome, and it is life-threatening condition. What are the presentation of contusion? Usually patient present with shortness of breath, it's called dyspnea, hypoxemia, blood supply less in oxygen, and increased bronchial secretion, hemoptysis, restlessness, decreased breath sound, and also crackles and wheezing. Added sound, right? And now pulmonary contusion. So what are the intervention in pulmonary contusion? We maintain a patent airway and adequate ventilation. Place the client in a polar position, so it is good for them for respiration. Admit oxygen, monitor for increased respiratory distress, and maintain bed rest, and also limit activity to reduce oxygen demand. Prepare for mechanical ventilation. So in this picture, we can see the contusion and bleeding occur in interstitial areas. And in this radiography, we can see the soft tissue shadow. And what next? Pneumothorax. So pneumothorax, most common. If patient have pneumothorax, it is pneumothorax, what does it mean? Means increase the air or fluid in pleural space. So in this picture here, we see the normal lungs, and normal lungs along with the pleural membrane. It is called pleura. And in between lungs and pleura, this is a space, it is called pleural space. Sometimes this area full of air, we call pneumothorax. When pneumothorax or air is inside, they compressed the lungs, and lungs does not get enough space to expand. So in this picture, we can see the air, and this is the parietal pleura, and this one is a visceral pleura. So pleura has two layers. One layer attached to the lungs, it is called visceral pleura. The other layer is attached to the ribs, and this is called parietal pleura. So fluid accumulate in between these two layers, and it is called hemothorax. When air is accumulated in this area, we call pneumothorax. So in this here, we see pneumothorax on expiration. And this is the chest radiography. We can see this is asymmetrical in between two lungs. And this is too much black rather than this, because too much air is here, and particularly this angle. So what are the description? So as I told you, in pneumothorax, increase the air or increase the thoracic pressure, but decrease the vital capacity of lungs. So usually the patient present few signs and symptoms we call data collection. Whatever the data, let me read it first. It is accumulation of atmospheric air in the pleural space, which result in a raise in intrathoracic pressure and reduce vital capacity. Loss of negative intrapleural pressure result in collapse of the lungs. A spontaneous pneumothorax occurs with the rupture of pleural cavities, basically. Also, an open pneumothorax occurs when an opening through the chest wall allow the entrance of positive atmospheric air pressure. A tension pneumothorax occur from a blunt chest injury or from mechanical ventilation when a build up a positive pressure occurs in pleural space. Then diagnosis of pneumothorax is made by chest X-ray. What next? What are the signs and symptoms if patient have a pneumothorax? Patient develop dyspnea, tachycardia, tachypnea, chest pain, or absent breath sound on affected side, or patient develop hyperresonance or decrease the chest expansion on affected side, or subcutaneous emphysema develop. Also, trachea deviated to unaffected side, and it is called pneumothorax. So if our patient have pneumothorax, what is nursing intervention? First of all, apply a non-porous dressing over the open chest wound, and also admit oxygen. Place the client collar position. prepare the chest tube placement, and we also put the chest tube. After put the chest tube, we should monitor the chest tube drainage system. We monitor for subcutaneous emphysema, or we collect the, when patient, first of all, as I told you, patient position is important, like high polar position. We monitor the vital sign. We take the chest X-ray and give them oxygen as prescribed. Also, dressing over the opened wound. So in this picture, we can see the chest tube placement, and also patient has a wound dressing. We prepare for the chest tube placement. This is the most important. Basically, in this picture, we can see this is the chest tube. Chest tube return the negative pressure to the lung space or pleura and remove the excess fluid or air. Also promote the re-expansion of the lungs. This is the chest tube use. And what is next? Next is acute respiratory failure. So if we do not take care of our patient, all of this complication lead to develop the acute respiratory failure, right? So in acute respiratory failure occur when insufficient oxygen is transported to the blood, or inadequate carbon dioxide is removed from lungs, and the client compensatory mechanism is failed. Acute respiratory failure causes include a mechanical abnormalities of the lungs or chest wall, a defect in the respiratory control center in the brain, or impair the function of respiratory muscle. So when a patient respiratory system fail or acute respiratory failure occur, it is occur because of maybe the mechanical abnormalities of the lungs or chest wall, or any problem in the respiratory control center in the brain. Because brain stem start expiration and inspiration. If any pathology in the brain stem or respiratory center, patient chance to develop acute respiratory failure, or impaired in the function of the major respiratory muscle, like diaphragm has any problem, or other major muscle. In oxygenation failure or hypoxemia respiratory failure, oxygen may reach the alveoli but cannot absorb or use properly, result in partial pitch of oxygen less than 60 milliliters of mercury. Arterial oxygen saturation lower than 90, and partial pressure of arterial carbon dioxide greater than 50. So when a patient have acute respiratory failure, if we take the blood for arterial blood gas analysis, we will see the saturation of oxygen would be less than 90, and partial pressure of oxygen will be reduced. and it is less than 60 millimeter of mercury, but carbon dioxide is accumulated in the body, and partial pressure of carbon dioxide would be greater than 50 millimeter of mercury. And many clients experience both hypoxemia but hypercapnia. Oxygen reduce in the blood, but carbon dioxide increase. And it leads to respiratory failure and also retain carbon dioxide in alveoli displaces oxygen, contributing to hypoxemia. So all of this leads to reduce the oxygen in the blood, and we call hypoxemia. Manifestation of respiratory failure are related to extent and rapidity of change of partial pressure of oxygen and partial pressure of carbon dioxide. If patients have acute respiratory failure, what should be the presentation, or what are the data collection, what we could see? So particularly if patient have any of them, patient present with shortness of breath, headache, restlessness, confusion, decrease the level of consciousness, tachycardia, hypertension, dysarrhythmias, and altered in respiration and breath sound. So you see here, when patient carbon dioxide go down, carbon dioxide accumulate in the blood, but oxygen go down, and also patient develop shortness of breath, we call dyspnea. When I have shortness of breath or difficulty of respiration, definitely it lead to the restlessness. Shortness of breath, less restlessness lead to the anxiety. Because of anxiety, my heartbeat will be go up, and it is called tachycardia. When heartbeat go up, abnormal heartbeat more than upper normal limit, and it is developed dysarrhythmias. Because of oxygen go down, but carbon dioxide accumulate in the body, it leads to the decrease the level of consciousness, right? Confusion occur. So if you put the stethoscope over the lungs, we found added or altered breath sound. Normal sound we supposed to get bronchial breath sound. We supposed to get vesicular breath sound or broncho-vesicular breath sound. But something altered, added sound will be added. In this picture, here showing normal alveoli, but here showing inflamed alveoli during in acute states. So normal alveoli, lung alveoli contain macrophage, is called alveolar macrophage. This is actually type of WBC. They act to defense mechanism. And this is the layer is called surfactant. Surfactant helps to lungs not to collapse. And this is interstitium. And this one, the capillary, where the blood vessel traveling, which is called endothelial cell, right? And here, gas exchange occur. But in this picture, we can see inflamed or injured alveoli look like a war field. The activated macrophage, this one is disturbed. They release the tissue necrotizing factor, interleukin. It is called TNF and IL. And also activate the neutrophil or activate the fibroblast. And we see they are activated the platelet in interstitium. Also, neutrophil is migrated to the blood vessel because they try to kill the bacteria, right? So excess secretion and patient develop the shortness of breath. So if patient have acute respiratory failure, what we will do? What are the nursing intervention? Identify and treat the cause of respiratory failure, give them oxygen to maintain partial pressure oxygen level greater than 60 to 70 millimeters of mercury. We place our client in Fowler position. In this picture, we can see the Fowler position. We encouraging the patient how to do the deep breathing, assist, administer bronchodilator, also prepare the client for mechanical ventilation. So particularly, we could check the arterial blood gas analysis. We determined acid-base balance. Also, prior to ABG, we checked the Allen test, and we would ask this question. We must check the pulse oximetry. And in pulse oximetry, we try to keep it 95 to 100%, and it is normal, right? Also, we give them oxygen, we call oxygen therapy. Like this picture, we can see patient position and nasogastric tube here and endotracheal tube as well. And this is the mechanical ventilation. So during the mechanical ventilation, what we need to know? We have to know what are the high pressure alarm, means obstruction. We need to know low pressure alarm, means leakage, right? So during the mechanical ventilation, when high pressure alarm means any obstruction, means excess secretion, client needs to be suctioning, or tube is kinked anywhere. Maybe the tube is kinked or displace the tube. Bronchospasm occur and causes increase the resistance, or coughing and wheezing. Also, frightening the ventilator. If the low pressure alarm means leak, we check the tube is disconnected or not, any air leakage or not, or we check for low cuff pressure, means not inflect enough, or the client stop the breathing spontaneously. So if the mechanical ventilation is not enough, then we go surgical management like tracheostomy, very important. Let me read acute respiratory distress syndrome. A form of acute respiratory failure that occurs as a complication of some of other condition, and it is caused by a diffuse lung injuries and lead to extravascular lung fluid. The major site of injury is the alveolar capillary membrane. The interstitial edema causes compression and obliteration of the terminal airway and lead to reduced lung volume and compliance. The arterial blood gas analysis level identify respiratory acidosis and hypoxemia that do not respond to any increase the percentage of oxygen. Let me recap it. ABG determined acid-base balance. And before or prior to ABG check, we always check the ALN test. Also, avoid the suctioning prior to doing ABG level. ABG stands for arterial blood gas analysis. Also, pressure to puncture site at least 5 to 10 minutes or longer if on anticoagulant therapy. Then we check the chest X-ray, show the bilateral interstitial or alveolar infiltrate. Interstitial edema may not show until there is a 30% increase in fluid content. And causes include sepsis, fluid overload, shock, trauma, neurological injuries, burn, disseminated intravascular coagulation, drug ingestion, aspiration, or inhale toxic substance, right? It is the underlying cause of acute respiratory distress. In acute respiratory distress, we see in this picture, this is the normal lungs, this is the trachea, but here we see the air is accumulated here and lungs does not get enough space because of pressure of the air. It does not expand enough. When this lungs is expand, but this one not expand, it is not symmetrical inspiration and expiration. It is called paradoxical respiration. So you see air in the pleural space, and this lungs is collapsed, and this is called puncture wound and develop acute respiratory distress syndrome. Other in these two pictures, it is the normal alveoli, normal lungs, and they easily inflate and deflate. But here we can see that alveoli is full of fluid that does not expand and contract easily, and also full of fluid, I said. Acute respiratory distress syndrome, what are the data collection? Patient develop trachypnea, dyspnea, decrease the breath sound, and deteriorate ABC level. Blood gas analysis will be less oxygen, more carbon dioxide, less saturation of oxygen. Hypoxemia, despite high concentration of delivered oxygen, decreased pulmonary compliance, and also pulmonary infiltration. So what are the intervention, right? So first of all, we identify and treat the underlying cause of acute respiratory distress syndrome, administer oxygen as prescribed. So we check the pulse oximetry, right? So pulse oximetry is supposed to be 95 to 100%. This is a normal. Also, inaccurate reading could be due to poor perfusion, right? When we deal with the patient, sometimes we have to check because some female patient has a nail polish, right? Because of nail polish, we will not get the accurate pulse oximeter reading. Sometimes patient need chest physiotherapy, right? Or oxygen therapy. So particularly, place the client forward position, restrict fluid intake as prescribed, provide respiratory treatment as prescribed, admin diuretics, anticoagulant, or corticosteroid as prescribed. Prepare the client for intubation and mechanical ventilation. This is the true picture, and we can see lung alveoli, normal lung alveoli full of air. And this is the capillaries where blood gas exchange occur. But unfortunately, infected alveoli in acute respiratory distress syndrome, alveoli is full of fluid. And now we are going to talk about the asthma, right? So asthma is a chronic inflammation or chronic inflammatory disease with bronchoconstriction or bronchospasm. In asthma, we see the mucosal edema with increase the mucus production. So in the picture here, like this picture here, it is the lungs, and this is the normal lumen. But in case of asthma, inflamed the lumen. Lumen is narrow, and in acute attack, the lumen is almost closed because mucosal edema developed with increase the mucus secretion, like this picture. Usually, the patient present with some sign and symptom we call data collection. What we can see in this picture: difficulty of breathing, dry cough, chest pain or tightness, usually night cough, shortness of breath, and wheezing. Some patients present with tachycardia or tachypnea, restlessness, and also when we put the stethoscope over the lungs, we get the wheezing. And most patients complain the nighttime coughing. So what are the diagnoses? How we diagnose the bronchial asthma? Particularly, patient give the history and physical examination we can get it out, or pulmonary function test can help to evaluate. If we check the blood gas analysis or EBG, we can get the picture, and also allergic testing. So the risk factor, sometimes asthma is hereditary. So carry out from family, pollution, infection, dust, pet, or some kind of food allergies, right? So when a patient comes to you, the treatment option, particularly I'm going to talk about the nursing intervention or teaching. So we educate our patient to avoid known trigger like dust, infection, pollution, allergic food. It is the trigger cause. During the acute attack, high polar position, and we give them bronchodilator. In this picture, you can see a man taking inhaler. Also, tell them to increase the fluid intake and also eliminate the milk. In acute bronchial asthma attack, it is good to tell patient for nebulizer, oxygen, antibiotics, and steroid, particularly hydrocorticosteroid or prednisolone. Sometimes prophylactic medication is very helpful, like albuterol. It is beta-2 agonist. And also we monitor the peak flow meter. So this one, the peak expiratory flow meter, it is good to monitor the asthma, right? And also we during the teaching, we will explain more. So let me read it first. As I told you, it is a chronic inflammation. So what are the difference between asthma and COPD? Asthma is a reversible, but COPD is irreversible. So chronic inflammation disorder of the airway, there various degrees of obstruction in the airway, marked by airway inflammation and hyperresponsiveness to a variety of stimuli or trigger. Causes recur episode of wheezing, breathlessness, chest tightness, coughing associated with airway obstruction that may resolve spontaneously, and it is often reversible with treatment, but COPD not reversible. Severity is clarified based on clinical features before treatment. When acute attack of chronic asthma, which is called status asthmaticus, means acute exacerbation of chronic asthma, and status asthmaticus is a severe life-threatening asthma episode, and that is refractory to treatment and may result in pneumothorax or acute core pulmonary or respiratory arrest. It leads to if you not treated well. So what are the intervention? We monitor the vital sign. We monitor pulse oximetry, monitor the peak flow meter, And during an acute asthma episode, provide intervention to assist with easy breathing. So in this device, peak expiratory flow meter, we can see three colors: green, yellow, and red. We call zone, three zone. So we educate the patient zone management, like green color. So green color means peak expiratory flow is 80 to 100%, and it is normal. So patient have to push the air through this opening. So with this inexpensive tools, you can monitor the improvement and worsening of all pulmonary function and asthma. So when you push the air, because of your pressure of the air, how far go, this is the indicator. If indicator come in the green zone, means asthma is well controlled. If indicator come in yellow zone, means peak expiratory flow meter is 50 to 80% of personal. It is the best for that person, and asthma is flared up. Maybe if it is here, it maybe go better, it may be worse, go down. So asthma is flared up. If the marker come in the red area, means peak expiratory flow meter is less than 50% of personal personal expiratory flow. And asthma is very severe and emergency care needed. Let me recap it. If the marker in the red zone means asthma is severe, emergency care needed. If marker in the yellow zone, asthma is flare up, it may be go worse, it may go better than green. If the marker in the green zone means asthma is well controlled. Here, patient education. So on the intermediate nature of symptoms and also need for long-term management. To identify possible trigger and measure to prevent episode. About the management of medication and proper administration. About the correct use of a peak flow meter, and also about developing asthma action plan with primary healthcare provider and what to do if asthma episode occur. In this picture, we can see a patient is using the meter dose inhaler. It is called MDI. So it is the meter dose inhaler without a spacer. But here we can see the spacer, and this is the meter dose inhaler. So when a patient needs to use this kind of meter dose inhaler, what we educate them? We educate them, we tell them to remove the cap and hold the inhaler upright, and tell them before to use, shake it out. And also, head is back slightly and exhale. Open the patient mouth, hold the inhaler 1 or 2 inches from mouth, or in the mouth, making a seal. And then tell your patient to press down or MDI to release the medication. When release the medication, breathe slowly for 3 to 5 seconds. Then again, tell them hold the breath for 10 seconds. And then exhale slowly through the pursued lips. Very important. And now let me talk about COPD. So COPD, also known as chronic obstructive pulmonary disease, right? So here, also known as chronic pulmonary lungs disease or chronic airflow obstruction or airflow limitation. Now here, chronic obstructive pulmonary disease is a disease state characterized by airflow obstruction and caused by emphysema or chronic bronchitis. So COPD, underlying causes emphysema or chronic bronchitis. It is the progressive airflow limitation and occur associated with an abnormal inflammatory response of the lungs, and that is not completely reversed. COPD lead to the pulmonary insufficiency or pulmonary hypertension, or it leads to core pulmonary. This is the picture. Here we can see the normal trachea, and here showing obstructive chronic bronchitis. This lumen is very narrow and inflamed occur. The thick, sticky mucus and block up the airway rather than the clears. And also inflamed or swelling further narrow the pathway. On this picture, we can see the normal lungs, the air exchange occur in alveoli. But here we can see the air exchange become difficult in damaged alveoli. And also the air become trapped. So in the alveoli, air go and air come. But here, once air go inside, but this air will not come back. As I told you, the underlying cause of COPD is the chronic bronchitis or emphysema. What are the difference between these two? Chronic bronchitis clinical diagnosis or daily productive cough for 3 months or more. Also in at least 2 consecutive years. Patient white change or patient is cyanotic blue discoloration, elevated hemoglobin level, peripheral edema is more common, bronchitis, bronchi and wheezing, added sound we found, smoking history. In case of emphysema, pathological diagnosis and also permanent enlargement and also destruction of ear space distal to terminal bronchioles. So in this picture, this is the permanent damage in the terminal bronchioles, usually older and thin, severe dyspnea. Or in X-ray, we found hyperinflation with flattened diaphragm. So this diaphragm is flat. When diaphragm contract and relax, it helps to movement our lungs. If our patient has a COPD, what are the common presentation, or what are the sign and symptom in case of COPD? What we could see. So sometimes patient present with shortness of breath or hypoxia. So you see cough, exertional dyspnea. So when patient do something, the shortness of breath start. Like angina, when patient work, chest pain start. And here COPD, when patient start to work, shortness of breath, wheezing or crackles, sputum production, weight loss, barrel chest. So usually anterior posterior diameter or transverse diameter is equal. Use the excessive muscle of breathing. So in this picture, we see accessory muscle in respiration, means this patient is struggling for oxygen. Prolonged expiration, orthopnea, or dysarrhythmias, congestion, and hyperinflation or chest exotherm. Arterial blood gas level that indicate respiratory acidosis and hypoxemia. Pulmonary function test that demonstrate the decreased vital capacity. So, first of all, in COPD, we see here distended bronchiole. This is the lung alveoli full of air and enlarged alveoli. And here showing the excessive mucus production and extra mucus lumen is narrow, inflamed airway, constricted smooth muscle. So in COPD, as I told you, emphysema and chronic bronchitis together we call COPD. Chronic obstructive pulmonary disease or chronic airflow limitation, or patients drive to breath, low partial pressure of oxygen, and lung alveoli. This is the lung alveoli, site of the gas exchange where respiratory acidosis, when carbon dioxide is trapped, also increase incidence who are smoker. So who are smoker increase the incidence in cigarette smoker. And this kind of patient has a chance to develop cor pulmonary, means right-sided heart failure. Here we can see the patient most of the times sitting in a chair with a feet spread, shoulder wide apart and leaning forward. Here you can see patient sitting on the edge of the bed with the arms folded and placed on a 2 or 3 pillow position over the nightstand. So if patient sitting like this, they feel good, right? And this patient present with shortness of breath or tired, easily fatigued, if you put the stethoscope over the chest, we can get wheezing, crackles, or recurrent cough, or patient sometimes present with upper respiratory tract infection, or increase the sputum production. Usually, most of the patients have a barrel chest, hypercapnia. So, patient develop respiratory acidosis. So, if you see the patient skin color, it is cyanotic in case of chronic bronchitis, or no cyanosis if they have a emphysema. Important. So now let me go about the nursing intervention, right? Or what are the teaching we could tell our patient. So educate your patient to, or first of all, assessment the respiratory status. It is very important. Check the vital sign. Admin a low concentrate oxygen, monitor pulse oximetry, and provide respiratory breathing, respiratory treatment, and chest physiotherapy. We instruct the client in diaphragmatic or abdominal breathing technique or pursued lip breathing techniques. Pursued lip breathing techniques can help them. And pursued lip breathing or deep breathing exercise is good. Tell your patient not to smoke, and smoking cessation is important. Avoid exposure to the cold or influenza vaccine is very helpful. And check for egg allergy. Sometimes some patients have a COPD, has egg allergies, or pneumonia vaccine can work, or tell your patient to avoid the milk because milk increase the mucus and high calorie, or also patient need high calorie, high protein, and low carbohydrate diet. So intake fluid unless contraindicated, increase the rest period, humidified air, and suction is necessary. Very important. Next here, suction fluid in from the client's lung, monitor body weight, encouraging small, frequent meal to maintain nutrition and prevent dyspnea. Provide high calorie, high protein, but low carbohydrate diet. Encouraging enough food intake up to 3 liter or 3000 milliliter per day. Place the client forward position and allow activity is tolerated. Continue. Administer bronchodilator as prescribed. So bronchodilator means it is good to give them ipratropium bromide or albuterol or salmeterol. Also steroid, admin the steroid as prescribed. Steroid oral inhaler like prednisolone or methylprednisolone But this medication has some side effects like poor wound healing, long-term use, patient develop Cushing syndrome, decreased immune response, or increased fluid retention or hyperglycemia. If patient has a diabetic, it is good to tell to adjust insulin level. Also, weight gain or patient chance to develop oral thrush. And as a prophylaxis, patient can use antibiotics. Next, continue chronic obstructive pulmonary disease. Adhere to activity limitation or altered rest period with activity. Avoid eating gas-producing food like spicy food or extremely hot or cold foods. Avoid exposure to initial with infection or avoid public crowd, better to avoid. Avoid extreme cold or temperature. Avoid pet or dust, pollen, environmental allergy, or avoid powerful odor, or meet nutritional requirements, provide or receive immunization as recommended, recognize the sign and symptom of respiratory infection and hypoxia, and stop smoking. So smoking cessation is very important. Use medication and inhaler as prescribed. Use oxygen therapy. Also use pursued lips or diaphragmatic or breathing exercise. So another disease is called severe acute respiratory syndrome. Respiratory illness caused by coronavirus and is called SART. S stands for severe, A for acute respiratory syndrome, or SAR is associated coronavirus. The syndrome begins with fever or an overall feelings of discomfort, body achings, or mild respiratory symptoms. After 2 to 7 days, the client may develop a dry cough and dyspnea, and shortness of breath. Infection is spread by close person-to-person contact or by direct contact with infectious materials. Or prevention include avoiding the contact with those suspected of having severe acute respiratory syndrome, or avoiding the travel to countries where an outbreaks of acute respiratory distress syndrome, avoid the close contact or frequent hand wash can stop the spread of the disease. In this picture, we can see patient usually present high fever, dry cough, shortness of breath, or change the chest X-ray, indicate pneumonias. So severe acute respiratory syndrome is a contact precursor we have to follow, or airborne precursor, pneumonia-like symptom at the beginning and causes by the coronavirus. incubation period usually 2 to 7 days. So usually it takes time to produce the disease, sign and symptom, and it is highly contagious.